But I think in the changing scenario where I think Dr. Abhinay normally does a lot of open surgeries, not MIS surgeries. I'm not sure whether his talk is relevant to the MIS surgery. Okay? Nonetheless, so as time is changing, we are doing more and more MIS surgery, and I think the freehand technique is out of bound in MIS in open surgery. So you have to do some sort of either X-ray based or navigated surgeries. All right. So I'm stuck in a situation between the hard rock and the brick wall where I have got the navigation, but haven't got the O-arm or 3D arm. So we bought the navigation system a year and a half back, but haven't got the 3D. So either I would start doing only X-ray based, or I innovate myself and do a navigation based on the 2D images. So why we need navigation? So it's optimize the workflow. It definitely reduces your radiation exposure both for the patient and the surgeon. It definitely improves accuracy and mitigate limit of fluoroscopy. Now, the benefit of navigation, as you know, that it improves accuracy, decrease exposure. It also pre-plan your screws. So in a workflow on the computer, you can actually measure the length of the screws. You can measure the length of the cage, diameter of the cage, and everything. It definitely reduces OR time after a certain number of cases you've done, not the initial number of cases. And it's definitely facilitates the MIS approaches. Now, it has a huge advantage in percutaneous. When you're doing a lot of MIS cases, I mean, freehand cases, there's no freehand technique in MIS cases, okay? You have to use a fluoroscopy, and there's hundreds of fluoroscopy you have to shot. So then, and if you're doing a number of 30 cases, 40 cases a month, the amount of radiation you're exposed to is immense. And the chances of you having some kind of thyroid cancer or other, we don't know about it, but it's really hazardous for the team and the doctor himself. So what are the component navigation? So first is imaging. You can do the pre-op image, pre-op CT scan or intra-op CT. Then you can have 2D scan. There is a computer workstation software. There's a camera. There are tracker system available, which is either active or passive, and you have references. Okay, now imaging, as I said, that there's a lot of imaging is there, and the modern imaging either 3D C-arm or you have got O-arm in the OR. How many of you have got access to O-arm? Wonderful, few hands. And how many have access to 3D C-arm? 1, 2. So overwhelming majority don't have access to O-arm or C-arm. So I'm the same scenario, same category where I have access only to the 2D C-arm. So what I do is, this is my workflow. So because of workflow, the software, latest software, very, very well-equipped software. They're really improved markedly over time, very sophisticated, better displays of images. Even with the 2D images are very good images, and they have multifunctional. So you can do the mapping of the screws. You can actually you can dock your tube. I mean, not only the pedicle screw fixation, you can dock your tube using the navigation, 2D navigation, case sizing, and there are color-coded screws as well. So as a whole, you can plan a lot of things, save radiation, save time. This is how I do it. I position my patient if I'm doing a lumbar fusion surgery. So navigation system is always on the foot end, and my C-arm is always on the head end if I'm operating from the left side. We clear all the metals out of the under the patient, and then I put the tracker. This is reference frame, which I always put on PSIS because I'm always doing MIS cases. So my option of doing spinous process, putting the frame on the spinous process doesn't exist unless I'm doing thoracolumbar spine cases, all right? So it takes hardly 2 minutes. Without shooting the X-ray, I put my frame inside. At PSI, it says directly bang it inside. And then I calibrate my instruments. These are the instrument tracker you have. You drape the patients, make sure the tracker is exposed to both to the machine. And what you need to do is you shoot a blank X-ray. First thing is you shoot the blank X-ray, and number 2 is you do the optimal AP shot. If you're working L4, 5 or 5S, make sure the pedicles are really round and plates are parallel. Sometimes you have to shoot two AP X-rays, one for 5S1 if the huge lotus is there, or one for 4-5. And then optimal lateral view. So these are 3 or 4 images you have to take. And the radiation doesn't take more than 3 to 4 minutes. And once the radiation is over, you register and merge into the system, and then start your pedicle probe. Or you start the pedicle probe, put on the lateral side, you see the pedicle and bang it up. So initial 10 cases, what I was doing is putting my C-arm in a lateral view, always, switch off the battery of the tracker, and then you, what you're going to do is, you're going to match the navigation and match the lateral view X-ray. So what are the tips and pearls? Always trust your instinct. If you think something is wrong, there's something wrong. Recheck with the C-arm. Take a live lateral image once pedicle probe is just medial to the pedicle to check whether they matches on both the C-arm and navigation. I will show you in the image. Re-registration done. If you have done a T-lift first, always register it, because once you've done the T-lift, then it's not the same. The cage expand the disc space. Then again, you have to shoot one blank AP and lateral. So this is an example how I do it. So if you look at this is after I put the Jamshedi needle on the navigation, and I match immediately with the C-arm. I put it laterally, keep the battery off, and shoot one. So there's a pointer here. Do you see does it work? So if you look see, this one match exactly. So I know that it's not off. So I'm very sure now. So this is just one X-ray shot. And then again, same. If I'm doing L5, again this image, and then I shot one other X-ray. I know it's matching it up. It is not fallacious, and I'm very confident now. So now I'm very confident, so I generally use X-rays. Once you put the guide wires in, and then you can do your T-lift job. You can, again, navigate your T-lift, and again check at the X-ray to see that your tube is at the same side to make sure it, and then you do your job. Once you've done your job, then you have to shoot one AP, lateral, and blank X-rays, and you put your screws. Okay? So this is how it looks like post-op. This is another example which I just did 2 days back. This was a grade 2 aesthetic, dysplastic pedicles. I shot one AP, one lateral, and then I first put my cage. The reason I put my cage because the disc was very collapsed. So I was not able to see the pedicle very, very well. So once I put the cage inside using the navigation technique, and this complete job, once the disc is collapsed, actually the navigation helps you going to disc space, because you don't have to shoot C-arm again and again and again. You know it is there. You can navigate your, the cage spreaders. You can navigate your the disc trials, everything. And then I put my screws. So we can do Olive same. In Olive, I think there's huge advantages because we know that Olive is completely C-arm dependent. So there are a lot of shots are there. So it really saves you, even if you have 2D navigation. So in 1 year and 2 months or 3 months, I have done 49 cases, T-lift, MIS-lift, Olive, and trauma. Majority of them MIS-lift and Olive. Total number of screws were about 226. Average resolution time, I'd say less than 4 minutes, I would say. So initial over time was very high because I was not sure whether I'm doing right or not. So I was shooting a lot of C-arm to check whether I'm right or not. But now I have limited it. And if you look at the fluoroscopic time, average fluoroscopic time in navigated MI-lift is 29 seconds compared to the non-navigated MI-lift, 79. And for 2 levels, really, it's 49 seconds. It's still high, but I'm thinking I'm improving. There were 15 guides which were revised. This is before I put my screws. So once I put my screws, I check in AP and lateral to see whether my guide wires are okay or not. Sometimes the guide wires are lateral. Most of the time, guide wires are lateral. Because you don't have actual image, so you cannot medialize confidently. You can only medialize confidently if you have the actual image to see how much medial you should go. So many of times I end up laterally and I revise those. And I revise those freehand using the C-arm. All right? It's a little difficult for dysplastic screws.
Please a little faster.
But no screw were revised. Once I put the guide wires, checked guide wire and AP and lateral, I was sure no screw were revised. And did a CT scan post-op to see because none of the patient had any symptoms. So limitation, there has a lot of
Prashant, you need to conclude now.
No actual image. Yeah. So it's limited clinical use in complex spine surgery, not suitable for any kind of rotation. Difficult to negotiate dysplastic pedicles, and midline is a problem. Thanks.